for those who can't make it. Fantastic. Thanks, Amelia. Okay, so welcome everybody to our Child Health and Wellbeing Network Huddle on refugee health in the North East and North Cumbria. If we make a start, Amelia, with the slides, thank you. Fantastic. We just would love to see who is joining us in the room today, so please do introduce yourselves in the chat and tell us a little bit about yourselves. That would be great. I'm Jen Hickin. I'm one of the network delivery managers in the Child Health and Wellbeing Network team. And if you aren't familiar with the network, I will just give you a quick overview of who we are and what we do before we get onto the meat of the session. Just a couple of housekeeping guidance for you, just to keep yourselves on mute while the presenters are talking. And do please make use of the chat function as well, because we will use that through the discussion and Q&A section in the second half of the session. So just to give you a bit of context about the Child Health and Wellbeing Network, we sit in the North East and North Cumbria footprint of the ICB, all the way from the top of Northumberland over to West North Cumbria and then down to the tip of North Yorkshire. So it's a really big patch, lots of well-known challenges for child health and wellbeing, big issues with child poverty and lots of complex health challenges which we are trying to address as a system. Thanks, Amelia. So the network has been on a bit of a journey. We are in the ICB currently, but we started life as an informal network with a bunch of enthusiastic professionals who really wanted to do something differently. And we've been through a bit of a convoluted journey through NHS England to where we are today in the ICB. Thanks, Amelia. So this is just our what we call priorities wheel. It just shows that the focus of our work has children, young people and families at the centre, and these interlinked overlapping priorities around the outside, none of them can be dealt with in isolation, and we have enablers and cross-cutting themes as well to underpin a lot of our work. And the main purpose of our work is bringing people together, working together in collaboration, driving work forward, sharing good practice as we are doing today, and just connecting people together to try and give children and young people the most opportunity to flourish and reach their potential. These are just some of those key headline figures. Oh, excuse me. Let's just mute those new people. Thank you. So these are some of the key headline challenges that we have around some of the health issues in our region. High rates of childhood obesity, for example, asthma and diabetes, long-term conditions in general are a big priority for us, neurodevelopmental, and then we have these huge numbers of children living in food poverty in our region, which is obviously has a huge knock-on effect for a lot of those health issues as well. Just by way of population, when we talk about children and young people, around 20% of the population is 0 to 17. When we talk about young people, we go up to the age of 25, especially when there's special educational needs and disabilities taken into account, and that's about 30% of the population. So it's a not insignificant number of people that we are here to advocate for. Slides are a little bit slow this morning, aren't they? This is what happens when we think that we're better off in the office on the office Wi-Fi, and it's not always the case. There are, if you could see it, there is when you get the slide set, you'll be able to see some of the resources that we have available through the network, one of which being the Facts of Life report, which we have available online, which shows some of the key challenges that we face across the region in terms of those specific issues that we encounter, and you can break it down across your locality, wherever you work or live, and you can see the key issues that you can perhaps work on through that report. Sorry about this, everyone. Okay. Sorry, Amelia's trying to get them back up for us. Apologies for this. We will be able to share, obviously, all the slides afterwards, and you will be able to connect with the network if you aren't already. You'll be able to join the network through the link that we put in the chat as well. So you'll be able to receive, thank you, there we are, fantastic. You'll be able to receive all the comms that we put out, any opportunities to get involved. That QR code that you can now see on your screens will enable you to fill in a quick form to register with the network, and we'll also put the link in the chat. And you will receive our weekly Child Health Tuesday email bulletin, which contains everything that you need to know about the network and some of the work that's going on in the region as well. Next slide, if we can. Yep, this is our youth board manifesto. So we obviously work quite closely in co-production with young people in our region. We have an amazing group of young people called the Know Our Impact Group, the COI group, and they've created this artwork you can see here and a full manifesto of how they want to work with professionals in our region, and together with our strategic oversight group, they act as a youth board for our work programme, and we'll share that link as well. And that's a fantastic video that explains in depth the work that they've done to create that artwork and the manifesto that they put together. Thanks, Amelia. And then just finally, I talked a little bit about advocating for that population of children and young people. We always share this quote from Sir Al Ainsley Green, who was the first Children's Commissioner for England, and he was really integral in the development of the Child Health and Wellbeing Network back in 2018 when we first started. And this is just a quote from one of his books, because this really is our purpose. We're here to advocate for the rights and the needs of all these young people who otherwise won't have anyone to speak for them. And I think when we're talking about refugees and asylum seeker children, they're potentially some of the most vulnerable and some of the least heard across our system. So that's what we're here to do today. So I am going to, hopefully, all being well, hand over to our brilliant chair for the day, who has stepped in to save our bacon, Dr. Stephen Owens, who is a head of department consultant and honorary senior clinical lecturer in paediatric allergy, immunology and infectious diseases, which is the longest job title I think I've ever heard at the Great North Children's Hospital. So Stephen's a consultant in paediatric infectious diseases, and he helps to care for refugee and asylum seeker children and young people referred for tuberculosis screening. He's also involved in a number of local projects designed to understand the unmet health needs of such children and to improve their access to healthcare. So we couldn't really have a better qualified chair for the day. So I'll hand you over to his safe hands to introduce our brilliant speaker lineup for you as well. Thank you.
Thanks very much, Jen, for the invitation to share today's session, and for that fantastic intro. I feel slightly intimidated now. The job title's notwithstanding. As Jen said, I am a paediatrician, and I do have an interest in this particular community of kids. Apart from the clinical role that Jen's described, I'm involved with some of the members of today's panel in a variety of projects looking to sort of understand unmet health needs in this population and ways that we can overcome the barriers in order to better care for them. So without further ado, I'd like to move on to our first speaker. It's Jessica Keeble, who is an inclusion health GP at Bevan House in Bradford, where she also is a training programme director for specialist GP training. Jess tells us that she's got a long-standing interest in working with deprived populations in Bradford, including those unaccompanied children who are seeking asylum. And she also acts as the safeguarding lead for her practice. So I think Jess is going to talk to us about mental health of child asylum seekers and refugees. We won't take questions immediately after Jess's session, We'll save those for the afternoon, or sorry, the second half of the session as part of a sort of Q&A and wider discussion with the panel, if that's okay. But please do put questions and comments in the chat, and we'll keep an eye on those, and that can help kind of inform the conversation that we have after the presentations are completed. So is that okay, Jess? Are you ready to start? I think Amelia's going to handle the slides for us. Thanks very much. Okay.
Thanks, Stephen, and it's lovely to meet everybody. It's inspirational, your network, and I'm thinking about, I'd love to join and replicate that locally here in Bradford. So yeah, I work for an inclusion health practice, and I have a particular interest in children, and I do initial health assessments. So next slide, please. I've been asked to talk about mental health of children and young people seeking asylum. And before they leave, by definition, people who have been forcibly displaced have suffered persecution, conflict, violence, or human rights violations. And additionally, children would have lost their normal protective factors and have disruption to their normal developmental opportunities. And we know that adverse childhood events have been shown to impact both physical and mental health in adulthood. And traumatic experience in early childhood can also decrease cognitive functioning, thought to be due to the impact of the development of the prefrontal cortex. A 2012 Lancet review found that the most harmful adverse childhood events were exposure to violence, either experienced, witnessed, or feared, and the loss of family support by death or violence, all of which are very common in vulnerable migrant children. And research into ACEs has furthermore shown that cumulative trauma has a much more significant impact than a single traumatic event, again, much more common in refugee children. Next slide, thank you. The next slide is just another picture, actually. There we go, of a boat. I just wanted to highlight that it's not just before migration that these children suffer adverse events, that it's during migration. Their trauma is compounded and their risk is enhanced by uncertainty, by parental separation, by traffickers. And I found this book by Gulwali Pasali really helpful in understanding the narrative. And I'd like to recommend that. I think that was good for me. Next slide, thank you. But it's not just before and during migration that these children suffer harm, it's after migration. After they get here, they face a very complex legal immigration process. And in fact, immigration law clashes with the 1989 UN Convention on the Rights of the Child. And when the government ratified it in 91, they entered a reservation in applying that to refugee children. And more recently, they've developed the hostile environment. There is social, cultural, and linguistic integration that these children need to do, which can be described as acculturation. Sorry, my pronunciation is not good at that. Now, this is a really slow, subtle, continuous process. It's very difficult to measure. But there's an interesting 2004 study into psychosocial adjustment of adolescent refugees in Australia that showed if they integrated well, they had improved psychosocial adjustment. If they remained separated from the host culture or assimilated into it and forgot their own culture, it wasn't particularly predictive of psychosocial adjustment. But if they were marginalised and lost contact, lost connection with both communities, it had very negative effects, and these children become very, very vulnerable. And as healthcare professionals, we need to note that these children also have difficulty in accessing healthcare. Doctors of the World work nationally, but they've got primary care clinics in London, and they've got advocacy services for migrants struggling to access healthcare. And back in 2014, when they did a survey, 82% of the people they saw hadn't been able to register with a GP, 29% for administrative and legal barriers, 17% because of a lack of knowledge and understanding of the healthcare system and their rights, 14% because of language barriers, and 11% because of a fear of being arrested. Next slide, thank you. So traumatic health experiences can cause mental health problems, and the symptoms of mental health problems may make integration more difficult. For instance, those suffering with PTSD may avoid stressful encounters, such as engaging with the asylum process. They'll re-experience feelings in triggering situations, maybe in large groups of people, in schools or waiting rooms, and they have increased arousal, which may lead to aggressive and uncooperative behaviour. Those who are anxious or depressed will have poor sleep, concentration, motivation, irritability, all of which makes it harder to integrate and to engage with health. Mental health issues are often stigmatized in different cultures, and so symptoms can present somatically, often as dizziness or headaches or body pains. Next slide, please. I don't know how well you can see that. It's not huge on my screen, but this illustrates a 2020 systematic review and meta-analysis that found that refugee and asylum seeker children have high rates of PTSD, at about 22%, anxiety at 15%, and depression at 13%. This compares to PTSD rates of 15% in the general population of trauma-exposed children and adolescents, and 2.6% of depression, 6.5% of anxiety in the general child and adolescent population. So the orange bars there are the vulnerable migrant population compared to a normal population. This paper also looked at oppositional defiant disorder. Perhaps we don't commonly diagnose this in the UK. It was a US paper, and that's the anomaly to the trend. But mental health problems are made worse by, next slide, by dispersal, detention and discrimination. PTSD, depression and somatic complaints all decrease with time if people are not displaced, but they remain if they are displaced. Detention, it doesn't happen as long as it used to, but there's a very insightful blog on the Young Minds website about how seeking asylum are being detained impacted on someone's mental health. And discrimination, opposition to immigration in the UK is high. It says on my notes moderately high, but I think I get the feeling it's becoming higher. Next slide, please. But only a proportion of those who live through trauma develop mental health problems. And I think it's often more helpful to look at factors that promote resilience, because children develop in their family, in their community, and in society. So it's useful to look at factors relating to the individual, the family, and community in society in promoting resilience. So individuals with a positive personality disposition may be more resilient, and we can support that with psychotherapy and psychosocial skills training that reinforces that child's coping efforts. The family, it's important to support families. We think family, a supportive, cohesive, functioning family can help resilience, and we can help that by supporting housing, providing support to parents. Community, supportive friends and restarting education and a positive school experience can all help resilience. Community building activities are important. And in society, mental health is improved by rapid resolution of asylum cases and policies to reunify children with their family and carers. And as health professionals, one of our roles is to advocate for that to our political system. Next slide. So when we spoke to a group of our unaccompanied child asylum seekers here at Bevan House. And when we asked them what they wanted health professionals to know, this is what they said. And if you could click through, that would be amazing. Thank you. And one more, that's it. Thank you. So they were asking to be noticed. Chris, in his introduction, said that this is a population who are not often noticed, but they are asking to be noticed. And it's our role and our privilege to notice them. So thank you for asking me to speak. I apologise because I'm actually in clinic this morning and need to dip out to complete my list, but hope to be back in time for the question and answer session.
Okay, thank you very much, Jess. That was fascinating and a great sort of introduction to the rest of the session. I imagine there'll be lots of comments and questions for later on, and hopefully, if clinical duties allow, you'll be able to dip back in to take part in that. That would be great. But for now, we'll move on to our second speaker, and that's Beth, who is a community midwife based here at Newcastle Hospitals. She's interested in forced migrant maternal health and has fairly recently completed an MSc in Public Health and Health Services Research here at the university, which is funded through the NIHR ARC scheme. Her research interests include migration legislation as a structural determinant of health, and she was recently commended or awarded Best Student Abstract for an MSc project, and has based her presentation today on that original presentation from last year. So again, I won't delay any longer and move over to Beth. Please take it away.
So thank you very much for inviting me to speak this morning. And I think that I'm going to talk about dovetails beautifully with what Jess has been saying. So it's a shame that she's had to leave. But what I want to make clear in order to lead on from Jess's, is that I will be talking about large-scale accommodation centres as the harm if they are used to house people seeking asylum during the asylum process, as opposed to detention, which tends to happen before people are deported. And incidentally, just so that you're aware, I must admit, I don't know how long children can be held in detention, but I do know that pregnant women cannot be held in detention for more than 7 days, because I'm a midwife, so that's why I know that. Also, you'll also see that my work dovetails beautifully with what Jess has been talking about, in terms of that we know that resilience for individuals and families is promoted when they're in a community and society session environment. So of course, large-scale accommodation centres would segregate people from that type of environment. So I've called my talk Now We See But Through a Glass Darkly, and any of you that know this will know that the end of the quotation is, and then we'll see face to face. And the reason why I've called my talk this is because I'm questioning the impact of migration legislation on the health and well-being of parents and children. So my interest is in how migration legislation might act as a structural determinant of health. So what that means is I'm interested in migration legislation as an upstream effect causing a downstream action. So generally, as health professionals, we tend to, understandably, because we're health professionals, we focus on downstream implications of things like access to, barriers to accessing to health, or what things we see affecting people's health. But I'm concerned with, well, what factors upstream are having this downstream effect. So this social determinants of a health approach to migration studies has been recommended by Castaneda and Honus in 2015. And in 2015, Fleischman conducted a case study in Israel about how the impact of migration could act as a social determinant of health for irregular migrants to Israel. But besides that, there is no other work in this area. So I just wish to thank my supervisors and the ARC. So North East North Cumbria ARC provided my scholarship. I'd like to thank my supervisors, Professor Judith Rankin and Dr. Lemna Gongola from Newcastle University Population Health Sciences Institute, and point out that the views own and not necessarily those shared by the Department of Health and Social Care. Could we have the next slide, please? Oh, cool. So I was just put this slide in just in case any of you aren't certain what a social determinants of health approach means. So if you were at the Marmot City conference in Newcastle last month, you'll have heard Dr. David Bush describe recovery for people who use drugs as involving somewhere to live, someone to love, and something to do, which Professor Marmot said, well, in a nutshell, that is the social determinants of health. And one of my community midwifery colleagues thought that actually also we should be including somewhere to live, somewhere to belong, which again reflects back on what Dr. Jess was just telling us. Next slide, please. Next slide, please. Gosh. Right, okay. So my thesis, the title of my thesis was Two Crises Crashing into One Another, and we'll come back to that in the final slide. So basically, my interest was, well, what as midwives do we know about how migration legislation might affect pregnant women seeking asylum? And the reason, the work that I'm going to share with you today was about midwives' views about plans for large-scale accommodation centres. And I know that this hasn't happened, but just to put this into context, the Nationality, Immigration and Asylum Act in 2002 made it legal that children and families could be held in large-scale accommodation centres, by which I mean things like former Ministry of Defence property, for up to 9 months, and that minimal schooling would be provided and not by local authority. The difference that the Nationality and Borders Act made was that such vulnerable people could be held indefinitely in large-scale accommodation centres. So whilst this might not have happened at the moment, we need to be aware that this is on statute, and that if there is a change to our political order, then this could come back again. And that is why, you know, I feel that we can go back to what Sir Al Ainsley Green was saying, of shout from the rooftops to protect vulnerable families that we're concerned about. So next slide, please. So the theoretical lens that I used for this work was an amalgamation of structural violence and the social determinants of health. So just to make it clear to you, structural violence comes from peace studies, and Paul Farmer was an anthropologist and medical doctor working in Haiti, and he described structural violence as social arrangements that put individuals and populations in harm's way. So this can be either deliberately or through negligence. So next slide, please. So I was using it in conjunction with the conceptual framework for the social determinants of health. And my concern was the impact of structural violence as the environment that can influence migration legislation, and consequently the final impact on health and well-being. And if you think, well, what Beth's saying sounds a bit over the top, just think about the hostile environment. We know that Theresa May instituted the hostile environment set of policies back in 2012, and we all live with that reality, as do these families that we're concerned with, but we're part of that as well, because the hostile environment has headed into healthcare, such that we now have to ask about people's visa status and people that, and questioning people's eligibility for free NHS care. Next slide, please. So just to make it clear, this was a thematic analysis, and every name that you see is a pseudonym. The study included 16 midwives from across the North East and North Cumbria, and you can see they were all a very experienced group of midwives. Next slide, please. Next slide, please. Right, okay. So at first I felt that I couldn't see the wood for the trees in terms of my results. It's like, what is going on here? And then next slide, please. Next slide. I felt that I had a eureka moment in applying some research here in the Northeast again among people who use drugs, who came up with the concept of stigma as a social determinant of health, which can widen the health inequality gap for those on the margins of society. Next slide, please. So this helped me come up with this model. The stuff that I was getting before, it was very clear that midwives were very, very concerned about segregating people, and they were concerned about stigma, and they're saying it's treating people like animals. They're really quite upset, some of the midwives, about the fact that this could happen. And we were also very clearly getting the fact that midwives were concerned about a widening of the health inequality gap, both through an increased experience of the social determinants of health and an overstretch of the of a rural NHS, but seeing stigma itself and the impact on healthcare really on the social determinants of health really helped put things into focus, both in terms of the fact that whilst you're not allowed to imprison people, that the barriers of an accommodation centre could start to become closed if guards start to control and exert too much power in the entrance and leaving of that place, or if indeed there's a hostile forces outside that place that can make it more difficult for people to leave. So I'll talk more about that with my results, if you'd just like to go forwards, please. Next, thank you. So the four main themes that came out of my work was the idea of widening the health inequality gap, an increased risk of stigma and safeguarding. This is all to do with large-scale accommodation centres. Excessive workload causing overstretch of the local maternity service, and increased risk of adverse perinatal outcomes. Next slide, please. What I'm going to do in these next few slides, which we can whip through fairly quickly, is just give you a taste of some of the results. So here on the right-hand side of the screen, you can see that a person I'm calling Kim, who was a midwifery lecturer, was saying, I cannot see any advantage for families and children of spending part of their childhood segregated from society in that type of environment. It's just storing up huge problems for the future. Next one, please. Next slide, please. And also the fact that if you've segregated people in a rural area or far away from, urban resources, that actually you're going to have huge barriers to healthcare, not only in terms of difficulties accessing public transport, but also language barriers as well. And things like, do they have access to mobile phones? And if so, are they aware that there's three-way interpreting available so that they can actually ring and ask for advice? And what I was talking about, the fact that, guards could control and exert too much control on who can actually leave. Go forwards. Next slide, please. Next slide, please. Okay, and stigma as a barrier to health and well-being. So not only you can see that my participants were saying, in a rural environment, people are going to be absolutely stigmatized. It's going to be so obvious who lives in that in what she's referring to as the old Ministry of Defence site. And interestingly, a rural midwife was actually concerned about whether it was going to be safe for midwives to go in to do postnatal care in such a centre, which was interesting for me as an urban midwife, because in urban, highly ethnically diverse areas, I don't think that's a question that you would have had midwives asking. And also there on the right hand side of the screen, you can see that Grace, referring to research from detention centres, was talking about how with stigma women can be less believed, and so as I was talking about the gatekeeping from guards. Go ahead, next one please, next slide please. So there also came out this idea of safeguarding risks both from within a camp and outside, because if there's not been vetting procedures on the occupants, the residents of a large-scale accommodation centre, is it going to be safe for the women and children there? And also, what about outside a camp? If you've got a large group of families, vulnerable families being held in a rural location is a risk of acting as a nexus for criminals that might wish to groom and exploit people, particularly as these families are going to have little money. Next slide, please. So, and finally, my colleagues were talking about overstretched maternity service. So in a rural area, it's more difficult to keep staffing numbers up anyway. If you have a huge number of extra people coming into that area, would there be too much work for the midwives that are there? Would corners be cut, which could lead to harm for those families? Would midwives actually get burnt out and leave, making things worse? Next slide, please. So you've also got the question of where are people going to get their specialist knowledge about forced migrant maternal health? Again, in my experience, I've learned experientially here within the city. But what about rural midwives? Where are they going to get that specialist knowledge from? Who is going to teach them? Next slide, please. So you've got a failure to recognise risk factors associated with forced migration could again increase adverse perinatal outcomes. Next slide, please. So just to finish, finishing my research quotes. So taking you back to the title of the talk. So here you see the quote on the right-hand side is asylum seekers are one group where equity isn't there. And we're at a point in time where it's an absolute crisis, and it's crashing into the crisis of Black women who live in the UK, who have poor outcomes, who already live here. Next slide, please. Next slide, please. Right. So to conclude, midwives were actually really good at assessing the health risks associated with the Nationality and Borders Act. They all thought that large-scale accommodation centres were not suitable accommodation for pregnant women, new mothers and babies. Migration legislation is a structural determinant of health which deserves more research. And migration legislation must avoid unintended harm to health in order to align to this sustainable development goal of health for all by 2030, which our country is a signatory of. So I've given you a couple of references for further reading. One is from looking at the use of large-scale accommodation centres for men here in the UK, and the other is about large-scale accommodation centres and the impact on health from Germany. Next slide, please. Next slide, please. So just to give you a quick overview of where we're up to in terms of the impact of migration legislation on health and welfare. So the Illegal Migration Act meant that people arriving from a third safe country were ineligible to claim asylum. This is what's caused a massive backlog in people's claiming asylum, and you could argue what it meant that we needed use of contingency hotel accommodation. So the Illegal Migration Act has now largely been overturned, so the processing of asylum claims from that era has started again. The Safety of Rwanda Act has now been repealed, so that means there's no longer talk of sending families or anyone to Rwanda. What we've got coming up is the Border Security, Asylum and Immigration Bill. This does impact families for us. Number one, it actually repeals the Illegal Migration Act plans for separated children to be the responsibility of the state rather than local authorities. So local authorities are responsible for separated children again, which is good, I think. Secondly, the Border and Security Bill will increase powers to detain people and deport them. So this is going to cause a lot of unsettlement for the families that we're caring for. Also, refugees who've arrived in the UK via small boats will be excluded from British citizenship. So this has got a big impact, both in terms of, are we going to end up with two classes of people? Are they going to have difficulty retaining employment? Are they going to have difficulty renting property? And how often will they have to reapply for leave to remain? And also, how often will they have to pay the NHS surcharge? So thank you very much. I think that's pretty well it. If you just go to the last slide, I think it's thank you with my email address if anyone would like to contact me. Thank you very much.
Oh, thanks very much, Beth. That was absolutely fascinating. And again, hopefully we can hear more or get you to elaborate on some of those points in the question session a little bit later, but it's really great. We're running a little bit behind schedule, but I think it's worth it for the quality of the talks that we're hearing today. And next up, we've got Rebecca Humphrey, who is a specialist health visitor for complex and vulnerable families in the North to 19 service, again, here at Newcastle Hospitals Trust, where Becky, I think it's fair to say, has got her finger in many, many pies, working collaboratively on lots of projects, some of which she leads in early help, vulnerable parent pathway, homeless accommodation, as well as relevant today, asylum and refugee seeking families and their health needs. So Becky recently led the 0-19 service through a successful sanctuary accreditation, which is fantastic news. And she's also successfully applied for charity funding to extend the health needs assessment, which is currently part of the service provided for children under the age of 5. And Becky's now extended that to 5 to 19-year-olds for the next couple of years, during which time we hope to gather some data and put analysis which hopefully will inform a bid for funding through the commissioners in this austere environment that we're all working in at the moment, to make this part of routine regular care for all kids, not just those under 5. So Becky is next up. She's going to talk to us about refugee and asylum seeking children, mental health and wellbeing, but specifically about the asylum seeking health assessments in children aged 5 to 19 years. Welcome, Becky.
Thank you. Good morning, everyone. So as Stephen said, I'm about to talk about what was, or naively I thought was going to be, a very small pilot has turned into a huge pilot, with numbers that I really wasn't expecting. So first slide. So what do we know, and why did we originally think that we needed the refugee and asylum seeking children health assessments? So refugee and asylum seeking children experience inequality in all aspects of their life, and health inequality is no exception. Their experience of healthcare on their journey can be very different to what we experience in the NHS. The diagnoses are sometimes very different to the actual real diagnosis when they arrive in the UK and are seen by UK medics. A really pertinent example was a little boy that I met, and he very clearly had a hydrocephalus development delay, and parents' explanation was that he had a very difficult birth, and he was given a buggy for his journey to the UK. This little boy, I actually took to A&E myself, so we walked up to A&E and had him seen, and he had a huge team around him, and has very good health outcomes, but it was not down to a difficult birth. So the significant exposure to trauma and repeated trauma has an effect not only on children's emotional health, but also can affect their physical health. The NHS is very often a new concept, and so are GPs and health visitors or school nurses. So building trust within families and communities is vital. One little boy who had delayed gross motor skills and was unable to sit, he couldn't crawl or pull to stand at 18 months, was referred into community paediatrics, started on vitamin D, which completely worked for this little boy. And however, he wasn't returned back to hospital to see the paediatrician. That paediatrician gave me a ring and said, can I get back in touch with this family? When I went out, this little boy was sitting, he was pulling a stand, and he was almost walking. But through further exploration around the needs of why they wouldn't actually come back to the hospital, it was because they felt that they'd experienced witchcraft. So that was a very interesting conversation with Dr. Grayson, I have to say. Next slide, please. So policy drivers, you've already heard from so many other policy drivers, which I've got on here, but and it's right that this should influence why health professionals should actively seek to identify and respond to the health needs of the child. But the one that I really want to highlight to you all today is the research from Newcastle in the serious youth violence. That will be available on the slides, and you'll be able to look through that. So it's not actually embedded into the research, but when I was presented with the research from the university, what they were saying was that they did have a high proportion of those children that they looked at first time entry into the youth justice system that had experience in the asylum process. And I found that really interesting when looking at the reasons for the young people being at risk of exploitation, particularly within Newcastle. And it discusses, so the paper does discuss the need for a sense of belonging and a need to find a trusted professional to work with and guide them through the youth justice process. And I think that's what we're all saying today, that these children and families are looking for help and support to navigate their way through life in the UK. Next slide, please. So what has brought us to where we are today, the need for the pilot. So the local 0 to 19 identified needs. Case study 1 was what was quite a significant case study. So I was contacted in my current role and asked if I would go out or actually arranged if I could see if a transfer in could happen for a family that had older children. There was no health visiting children at the time, and that was from one of the local authority support workers. Home Office had made them aware of a family that would potentially need help to register with a GP fairly quickly. So Jenny went out and met with the family, and it was very clear that there was health needs for that family. So Jenny contacted me and asked if I would be able to arrange a GP appointment. Without going out to see them, I didn't understand why I needed to arrange a GP appointment fairly quickly. However, as soon as I arrived into that property, it was very clear that I was presented with two boys who actually wasn't sure if they were alive. They were so emaciated, they were unable to move independently. They had no swallow. But again, mother had told me that the children had cerebral palsy from birth. They arrived into this country and were taken to a previous hotel in a different part of the country. When they arrived, it was very clear that they shouldn't be in a hotel. So they spent one night in that hotel and were moved very quickly with the aid of a buggy and a taxi to Newcastle. And as soon as I seen them, as you can imagine, I didn't know what to do. So I contacted Dr. Stanley, who took that phone call, and I said, I don't really know what I'm supposed to do here. But we very quickly got them into hospital through A&E, and again, they have a huge team around them supporting them. Or learning from the Home Office Family Hotel, that's now closed in Newcastle. However, the needs were collated throughout the whole process of having that hotel open, which was initially for 3 months, but did last over 2 years. But it was very much public health needs, dental health, healthy weight, low weight, low BMI, and mental health. Domestic abuse was very high, and FGM in girls was identified. And this is how North now have a new pathway for under 18-year-olds who have experienced FGM in their home country. And without the voices of these young women asking for health appointments for their experiences, we would not have achieved a new pathway in North. So I'm very proud of that. Next slide, please. So what happened next? The Trust Board of Directors were very keen to know a lot about the case study 1 that we've just talked about, and the family agreed to be videoed and presented to the board, and that was a little while ago now. Again, got support from paediatricians, so building the team of support around our refugee and asylum seeking population. Stephen and Ruth are incredibly supportive of everything that we're doing. And this led on to charity application for funding, which has led on to the pilot that we're talking about today. But also along the journey, we've also worked within the Trust, local voluntary service agencies, and the National City of Sanctuary. And as Stephen said, we've just been accredited as the first 0 to 19 service of Sanctuary. So I am buzzing. I love that. Next slide, please. Development of the pilot. So through the learning around what we've know about the families and knowing that there were potentially a huge number of school-aged children out there in the community with increased needs, we needed to develop the pilot that is now almost halfway through. The aims were to gain a citywide understanding of the needs of the population so that we wouldn't normally know about. So we wouldn't necessarily know about these children unless they were highlighted specifically to us, like the family in case study 1 or the hotel. So since the closure of the hotel, we really need to be able to identify these children, as there's not one easy process of being able to identify if a child is a refugee or asylum seeker. And the Home Office will only share information with the local authority partners when they are concerned. The pilot has been shared with lived experience parents and young people who have been willing to support us in this journey, and North Charities supported the pilot and funded the post of one whole-time equivalent skiffing into the pilot for 2 years. Next slide, please. So current findings, the figures we've got so far highlight that the school age population already outweigh the preschool population. And I'm not expecting that to change dramatically once those babies are born from the unborn population. And that is purely because there's a cohort of health visiting children moving into the school health population. Next slide, please. So the health needs, overwhelmingly there are dental needs, lack of immunisations and significant physical health needs, which need referrals on to paediatric services within our GNCH. And mental health needs. Although mental health needs are the fourth most common need, what I would really like to recognise is that all of these young people that we've met have some form of trauma impact and emotional health needs. However, the 9 that we've documented here are the ones that have required further support from specialist mental health services. And that is because one of our senior school nurses worked into the suicide prevention team for a year on secondment, which then led on to the development of the emotional wellbeing pathway in the 0 to 19 service for young people. So the whole 0 to 19 service is actually trained in enhanced emotional wellbeing training, which means that we are able to deliver an enhanced mental health support as a first-line practitioner, and be able to understand when we actually need to move on to more appropriate services. Next slide, please. So when we do meet with the young people, it's on average about 6 contacts that we make with that young person individually, and that's a package of care that we deliver, and that is around building a relationship, being able to go through the health assessment, understand the health needs, and also understand the impact of trauma. And this is one young person's feedback, which she has very kindly shared with us. So what I've got to say about these sessions, I don't have anything bad to say about it. I learn to listen. I download all of my anger inside of me. I could speak out. Every teaching and exercise you teach me in the session, I felt comfortable to be able to speak out about everything I want to talk about. I never felt uncomfortable to talk with you and thank you for your help, which is just so lovely to hear. Next slide, please. So the next steps, I was hoping George was going to be here to read this bit out, so I will, my notes say over to George, but I don't think he's here. So in the short term, we will audit the data and gain a better understanding of the health burden for refugee and asylum seeking children in Newcastle. We'll compare the number of referrals made in the 5 to 19 age range and the 0 to 5 age range to gain an idea of the increased benefit of expanding the service. And in the long term, we will have a qualitative study interviewing asylum seeker and refugee children in depth on their experience of healthcare in the North East, and hoping to have a health economic study comparing the health burden of the refugee and asylum seeking population to the North East average, and overall have an understanding of the health burden and how best to address it. That's the last slide. Thank you very much for listening.
That was fantastic. Again, thanks very much, Becky, and apologies on behalf of George. He's just started a new job over the Freeman and is on clinical service this week, so he can't get away, unfortunately. But no doubt we'll be hearing more about the project and the analysis of the data over the next kind of few months, and perhaps we can present it again at a future huddle. But for now, we're going to move on to our last speaker, who I think probably everyone knows now. It's Chris Harkensey, who's another paediatrician, a colleague of mine, formerly worked in Gateshead and is now currently up in Dumfries and Galloway, but still retains a role here in the North East as the Health Inequalities Advisor for the Child Health and Wellbeing Network. He's a humanitarian. He's deployed overseas with different organisations to deliver healthcare in austere and challenging environments, and as I say, previously in Gateshead, he provided a clinical service, a sort of one-stop shop for families, refugee families, together with local GP practice, delivering primary care to vulnerable populations, and has got a huge amount of experience and some data arising from that, and I'm sure he's going to tell us all about it now. Over to you, Chris.
Yeah, thank you very much, Stephen. Next slide, please. So I'm sharing today some data, which is an update on data I presented previously, a little kind of looking back at physical health needs, but then also exploring how that all links to mental health and well-being. So this is just a recap of growth data that we have from the local cohort of refugee children in Gateshead. We had around 200 children that we saw over a period of about 5 or 6 years. And what we can see here that the children who come do have issues with being malnourished, not acutely, but more chronically malnourished. So quite a proportion is stunted, meaning they're short for their age. Some are underweight and some are also overweight, plus minus stunting, which poses significant future health risks. What we also found when we measured their levels of vitamins and ions in the blood, there were very large numbers of children who had who lacked micronutrients. Vitamin D, the most common, but also iron deficiency, vitamin A, a proportion of 15% had actually manifest iron deficiency anemia. Next one. So this is an overview of the health needs that we identified, which reflects what Becky was just presenting before, perhaps in a bit more detail. And what I put in red here are probably the most common, more than 20% of all children affected, which is vaccination status, micronutrient deficiency. So almost all children had at least one, vitamin D deficiency, some form of malnutrition, and some problem with gastrointestinal system. And we see mental health diagnosis. So this is having actually an existing diagnosis rather than having symptoms or a suspected diagnosis is already more than 20%. And then slightly less common, more than 10%, various micronutrient deficiencies, but also some chronic conditions and less frequent specific infections, including TB and some other more chronic health conditions. And then there is also quite a number of more unusual diagnoses. Next slide. So we undertook a mental health screening, and we did that by doing the Strengths and Difficulties questionnaire, which is a quite commonly used tool in refugee children. In particular, there is a number of very good studies from Australia. We also checked a number of psychological symptoms which are commonly reported, like separation anxiety, sleep problems, and so forth. And we passively explored ACEs. So we were not actually sitting there and asking, oh, did you have that ACE or that ACE? It was more like what people told us, and we recorded that. And again, the numbers were staggeringly high. We also looked at psychosocial risk and resilience factors, and I will come to in more detail to that. But what we could see that about a third had abnormal risk scores and risk and combined protective scores as well. Next slide. The SDQ results, this is the overview, and we compared that to what you could say is a UK standard. So there is a number of publications which have done SDQs on large numbers of school children. So we have a fairly good idea what the UK population has. And we found that in view of total score, impact score, emotional score, conduct, the factor of score is around double that of the UK child population, except for hyperactivity. What is interesting is that the refugee population had a higher resilience or pro-social score, which is actually a good thing. Next slide. So this is what we found with regards to adverse childhood experiences. So this is an extended set of ACEs, which includes the refugee experience. And what was very common is interrupted schooling, emotional abuse, not necessarily in the family, more from the experience of their conditions of living in a war zone or very impoverished situation. Directly witnessed trauma, we heard that before, is a very predetermining factor, family separation, and also experience the death of the nuclear family member, which is a parent or a sibling. Next slide. So this is a bit of a busy slide. This demonstrates statistical associations between factors such as SDQ scores and demographic factors, but also physical health factors. And what is quite striking is that there clearly is a link between abnormal SDQ scores or a mental health diagnosis with some physical health aspects, including aspects of growth and aspects of micronutrient deficiency. Next slide. Next slide, please. So this looks at the SDQ scores in particular. As you can probably imagine, as SDQ is a mental health and well-being tool, all psychological symptoms actually strongly associated with that. What we could identify is that you have more normal SDQ scores or productive associations if children had high ambition, were in school, had good peer support, parents were learning or speaking English, they had good housing. And that was quite a consistent finding. Risk factors, and Jess has highlighted that, is not just about previous experiences. I kind of detailed the ACEs here, but also about current experiences after migration, such as bullying, poor housing, not being in school, or what was quite common as well, parents having a disability or mental health problems themselves. Next slide. So the bottom line is that the previous and current risk factors that associate with poor mental health and well-being and poor physical health as well. And these include ACEs, but also child and parent experience of violence, bullying, discrimination, mental health problems of parents, poor housing and lack of school access, and key resilience factors, meaning we see less mental health problems if children are in school, if they have supportive peers, which is usually through school, if they have good housing, and if parents speak English or are on courses to learn English. Next slide. So the bottom line here, what we can do as health professionals is that we do some kind of mental health screening, which can be any of the tools which are presented here, including the SDQ score, to actually have an understanding of mental health and well-being issues which may not be explicitly stated. We can advocate with the responsible agencies in view of housing, access to school for children, and English courses for parents. We can look at things that promote wider integration into society, such as access to their own community, but also access through, for example, charities or other organizations to feel more at home. School access, again, is something that integrates parents because they do get in touch with the school as an organization, with other parents, with other children. So this seems to be a very strong factor. And then also do a thorough physical health screening, including growth and micronutrients, because of that close link with mental health as well. Next slide. So what we see, and that is my experience in talking to many families. So families don't come here with a purpose of claiming benefits. They all have a vision for a safer and better life. Often they come here for a safer and better life for their children. They have gone through incredible journeys and still maintain that kind of determination to succeed. And we should recognize the contribution that refugees can make to our society. So this goes back to what Beth said as well. Many come here with the willingness to actually be part of society and put their effort and the skills and often already the training and qualifications they bring towards the better of society and the better of their own life. And it is an opportunity for our country to actually give citizenship to people who demonstrate that. Next slide. Yeah, I finish here, so my email contact is there as well. Thank you.
Thanks again, Chris. Every time I hear an update on your analysis from this work, it's absolutely fascinating, and the arguments just get stronger and stronger for the conclusions that you've drawn, to my mind. We've now actually, thanks to a bit of a buffer that's been built into the timetable, sort of caught up with ourselves a little bit now. Hopefully you can start the next sort of Q&A session at 11:15. Between now and then, if the panel and the rest of our participants would like to take a short break, and then we can get online just before 11:15. We can start promptly with the Q&A session. Thanks very much, and see you shortly. The first question, but I don't want to monologue, so I will now open the floor to participants who would like to ask any questions of our panel. I've got a few things that I've noted down that I'd like to talk about, but has anyone got anything? There's not a huge amount of stuff in the chat, but has anyone got any questions or comments that they'd like to make? Oh, Marika's got her hand straight up. Brilliant. Marika, take it away.
Yeah, well, thank you all for brilliant overviews that you've all given. I was struck by Beth's talk about the pregnant women, and I was wondering how you translate what you find into practice.
Could you explain what you mean a little bit more, Mariaka?
Well, you say there's a lot of inequality. There's a lot of fear going on. How do you do that on a day-to-day interacting with immigrant women who are in these situations? How do you put them at ease? How do you make sure that they do get the care that they require? I mean, we're obviously also aware that some of these migrants tend to be moved overnight, and then you've lost them. And then I think also in the community, that's something that was highlighted. It can be very difficult to track our children. I mean, I collaborate with Stephen Owens as PEDS infectious disease consultant. But how do we address this? How do we make sure that these patients do get the appropriate care?
Well, I mean, I think that is that's a question for that needs raising with the NMC who set or whoever sets the education. I certainly know from the lecturers that were involved, they were saying, well, we do include some stuff about refugee health within our training, the midwifery training that we're giving, but that is alongside other inclusion health, the needs of other inclusion health groups such as homeless people, etc., etc. So I would question whether or not within midwifery, and I would say personally I don't think there is enough education within midwifery education full stop about the needs of vulnerable migrants, and personally I think there needs to be more push for educating midwives better as well, because at the moment I would say that what the RCM has put out is about, you know, be aware of trafficking and be aware that people can get moved at short notice and so on, but there needs to be more awareness of things such as what Chris was talking about you know, chronic malnutrition to do with vitamin D and so on. But I would say that with it, certainly within Newcastle, the fact that community midwives are you know, we caseload, I think that gives us a chance to focus in on the needs of our women more closely. And Newcastle have just started having a specialist midwife for vulnerable people, and certainly one of my participants, of course I can't say where, in the northeast North Cumbria, who took part in my research, the work that they were doing in terms of the specialist service they were doing was absolutely exemplary. Hope that helps.
Excellent. I think Becky Humphreys has got her hand up next.
Yeah, so I just wanted to say really that as part of the City of Sanctuary, where we've got a 3-year accreditation, and during that's about ensuring that the whole service raises its educational levels around migrant children. So it's not you've been accredited sanctuary status and that's it, you're going to keep it forever. It's about being able to demonstrate what we've learned throughout the whole 3 years. That it took 2 years to get to the accreditation point, and then within the next 3 years. So we are continuously educating our whole workforce, and it's not just about, certainly not just about the 0 to 19 service. So our next education day, which is in March, that is including all of the junior doctors, it's including all of the specialist nurses from GNCH. So with a really wide spectrum of inclusion within the trust, really, and working with partner agencies to build those relationships, not just with the families, but also with your voluntary services that help and support you on this journey of it, which seems never ending in terms of getting it onto people's agenda. I know certainly from my perspective, I do travel quite a bit with work and talk about the needs certainly within Newcastle, and we are up there and we are highlighting our work. And it does seem like we are going above and beyond in our city, which is really, really good to hear.
Becky, just as an aside, are you able to put details of that next meeting, the training session in March, in the chat, or is it not yet sort of, you know?
Yeah, it's a full day at the Freeman. You get a cup of tea, and I think we might actually have biscuits. And we've got such a packed agenda for so we've got lived experience workers coming, which is brilliant.
Well, I'd love to attend, and I'm sure there's other people on the meeting who might like to try to. Is it going to be a hybrid meeting, online as well as in person, or? No,
it's just in person. Alice Wiseman's coming as well, hopefully, and George. So that's good.
Is that aimed at adults or?
So it's for no children. Anyone working with kids.
I just noticed it's in the Freeman.
Yeah, so that's the education centre that we could book.
Stick the details in the chat, Becky. That would be great, and I'd love to attend that. Ailey Hodgson, Some Tyneside, I think you're next up.
Hi, and thank you to everyone for all your talks. That's been really, really interesting this morning, and I'm really, really pleased that I came along to this. I work for the Northern Neonatal Network, and I'm just really interested about the impact for these families on neonatal stay. We have a lot of families, myself and Sarah, Brooks, who's also in the talk, in the audience, we talk to a lot of parents and families, and there's an increasing number of families from refugee status. And I'm just thinking about the kind of the the trauma of having a baby either born early or having a serious illness, and that separation from parents and their babies, which is often the case in neonates, especially in the level 1 units closer to home, because there's just not the infrastructure for families to stay together. And there's often a lot of kind of funding and travel and accommodation issues for these families. And I'm just thinking about the kind of the statistics that Chris showed earlier were just so sad. And I know there was a positive slant to his presentation, so thank you so much for bringing that in. But just thinking about all the kind of adverse effects that then having a neonatal experience would have, and I'm just thinking about the link with maternity, and we've got midwives here. I just wondered if you had any kind of advice about how we as care coordinators make sure that we are supporting these families even more than we are. I'm thinking about, I mean, there's kind of like the obvious things like translating resources into languages that would be kind of relevant to the different pockets of the communities across the region, but anything else, like, you know, neonates is an area that, like, so for example, in Cumbria, I support the 2 units in Cumbria. They don't have any psychological support for families that is easy to access. So I'm just thinking it just kind of seems like it's a much bigger problem than we kind of realize. And I just wondered if anybody had any advice, basically. Sorry for the monologue there.
Maybe I can make a start trying to answer that, but I think Beth probably would know as well. I would say the most important thing is to, you know, being aware of what the potential barriers are, what the potential issues are, and being proactive and exploring that with the family and listening well, you know, what they have to say and what they perceive as their health needs and what they would like to have addressed, and being responsive to that. Yeah, I think a lot of that stuff can be anticipated and addressed already kind of during maternity care, and perhaps a good coordination between maternity and neonatal care would be good. So if that information could, for example, be shared from midwives saying, we have this lady coming in, she's a refugee, we expect, I don't know, a premature birth or whatever. And these might be the needs of that mother or family after birth. And also being, you know, having a wider lens approach about how does that impact on the rest of the family, because the neonatal care of a premature baby, for example, will absorb a lot of the time and effort of the mother, and what does that do to the rest of the family?
I think there's been, sorry to jump in, but there's been a few cases where families have been kind of displaced because of neonatal care. You don't necessarily get to go to the unit closest to your home. And so you know, there have been families that have been separated, and you know, older siblings haven't been able to come and be on the unit if the mum has got a bed, for example, and it's just been really, really difficult. And I don't think there's enough funding for families as well, because they have their own limited pot of funding, but it means that they can't access other funding like the family fund, for example. And it does feel like things are so difficult for these families. And I know they are across the board, but just, yeah, and I understand that's really, really good advice, but often it's not a planned pregnancy, it's a spontaneous delivery, so it's not necessarily going to be that kind of ability to have such a well coordinated plan in place prior to the delivery. But yeah, no, I think maternity and neonatal services working together is fundamental, and there's the preterm birth midwives, which we have quite a lot to do with, and that's been a brilliant resource. But yeah, thank you very much for that.
That's great. I'd quite like to move some of the comments and questions to Jess's talk in a moment. I see she's got her hands up there and probably wants to comment on what's just been said. But Sarah Brooks, I think you were next up. If you'd like to make one last comment on this particular area, and then that feeds in nicely to Jess, who can ask her question, and then I've got a question for Jess. Is that okay?
Yeah, sure. So I'm Sarah, and I'm Ailey's counterpart. But I started my role as care coordinator in January this year. But before that, I was the lead for the outreach team at South Tees, the neonatal outreach team. And unfortunately, we had delayed discharges because of the coordination to support families that were seeking asylum. I did lots of work with the Family Hubs network as well, which had some wonderful resources and had some wonderful training. But unfortunately, we weren't able to access that. So it was the coordination between support that was delivered by the local authority and the NHS services. The neonatal units are doing their best and life-saving, and I think life beyond the neonatal unit is a very different image from everybody else. So the midwives have their work and their support and their training that they do. The neonatal unit are saving their lives and are struggling to think of the wider community and the support that is available beyond that. So it's about delivering a service that is and reaching out to other commission services that are available. We had some training through Justice First, which is a North East charity that gave us some information, but that kind of information needs to be across the 10 units that cover our local authorities. So yeah, I think it is about communicating with those already commissioned services that are out there to offer support and recognition that the neonatal families. Through the first talk, I made some notes, and you know, the families, it's already recognised that the families are, it is a trauma coming to the neonatal unit, but lots of these families have already had significant trauma before actually entering the unit. And as Ailey said, not all of our units have that psychological support there for the families. So yeah, it's about everybody working together and recognising what we can do through local authority and through NHS to improve the systems, I think, that are already in place.
Yeah, thanks very much, Sarah. I think that's right. You know, clearly there's a huge problem sort of connecting services and integrating care for these families across those different sort of specialty areas, and that doesn't really exist, it seems to me, in a sort of properly structured way. I mean, perhaps one thing that the Child Health and Wellbeing Network can at least do as serve as a network and a means to sort of connect like-minded individuals across different sectors who might be able to at least point people in the right direction for particular questions or needs, and over time help to strengthen services through huddles like this and through advocating and, you know, getting involved in policy discussions and so on. I would like to move on to Jess. Jess, I think you've got maybe a question to make around this one point, and then I've got something I'd like to ask you about your opening talk, if that's okay.
Yeah, of course. I wanted to echo really what Sarah said there, but I think, you know, I find that people, when you become a trusted professional to them, they will come to you with all their needs, and they will come to you with their housing needs, and they will come to you with needs that you're not trained to answer and that you're not particularly experienced in answering. So I think making links with the City of Sanctuary and, you know, with children's social care, with other non-governmental organisations is really important. We have social prescribers in primary care who support us with that, but there's a website called Treacle, which is really good at sort of signposting to local resources, and that's a national resource. So I think that might be helpful if you get stuck and there's a family presenting with a need that's something to do with housing or something to do with immigration, that you may be able to use that to signpost them to some good resources.
Okay, thanks very much, Jess. I'm just looking for that. I've just found that website now, and in a moment I'll pop it into the chat so people can have a look. Jess, can I move on and ask a question around your talk, which I thought was a really good excuse me, introduction to today's topic. Some of what you said, or a lot of what you said, actually was reflected later in Chris's talk. I know you had some clinical obligations this morning. I'm not sure how much of Chris's talk you heard, but I was struck by the stuff that you were talking around the importance of integration and how the impact that later has on psychosocial outcomes, good and bad. And I think you referenced a study which is about 20 years old from Australia. Could you say a little bit more about that? Because I think we might come back to that again when we talk about what some of the findings that Chris has made in his own study within his clinical service.
Yeah, I think that it's fascinating, isn't it? we often see a difference within a family of integration, children integrating perhaps faster with than their parents, and then acting as cultural mediators, which can introduce stress and strain to a family and be a source of problems, really. But I think, because sometimes when a child integrates quickly, then maybe they're not integrating, maybe they're assimilating with our culture and wanting to distance themselves from their own culture. So that process of integration is, I suspect it's not very well studied, which is why I've had to quote a study that's 20 years old and that was very small. I think there are theories that there's a hierarchy and integration is best, and people who are separated from both cultures is worst, and the others are somewhere in the middle. But the study I found, which was very small, seemed to suggest that those in the middle who were I forgot my words, assimilating or separating or assimilating weren't actually that predictive. But that we talk a lot about diversity and inclusion, and I think it's difficult to achieve, and it's difficult for these individuals.
Absolutely. Anyone got any questions or comments about Jess's talk, which gave a broad overview to today's theme?
Just to thank you, Jess. It was really, really good.
Yeah, absolutely. It was, very kind of powerful place to start from. I think integration is a fascinating one, isn't it? Because it's often talked about in the sort of political sphere and in the media as something which is on the onus of these individuals to do for the benefit of the host society. So it's actually extremely important and useful to think about it from the position of the actual people arriving here, and from what it means for them, rather than imposing, as you say, a sort of concept of what good integration should look like on them. I'm thinking a lot of the teenagers that we see in our clinics in particular, and the struggles they have.
Yeah, and the challenge, if we have a system that is intentionally hostile, it doesn't allow them to do that easily.
Right. Well, if there are no other questions for Jess, I wonder, I think if we move on to Becky, and hopefully then we can maybe come back to speak to this again if anyone's got any other questions for her. Becky, I'm going to open my question to you. Obviously, this is something we've talked about before, but the whole, the sort of the overall objective from the pilot program is to sort of build a case to make this a sort of an ongoing component. This sort of health assessments for these slightly older children, the 5 to 19s, making it a sort of statutory requirement and making sure that it remains permanent. What do you see? This might not be unfair, and maybe other people might be in a better position to answer it, but what do you see as the chances of that happening, given the current sort of financial environment that we're in? We're all being told about the cost improvements that we've got to find and how there's no new money for new services. So, how do you think that what are the chances of us achieving that sort of permanent commission service? And what can we do in terms of strategy to optimize those chances? Obviously, we're going to build the case of the data, but it seems to me from these very early stages, you're already developing a very powerful case.
Thanks for pre-warning me about that question.
Sorry.
So what I would say around that is building the network, building a national network around how other people have been able to get this service commissioned. And what I've found throughout the last 2 years is that our numbers outweigh other numbers in core cities. Working with colleagues in London, Liverpool, Sheffield has been really beneficial and has really influenced our pilot. And just the learning that they've gone through, that has been able to benefit us as well. our commissioner is fully aware of it, aware of the pilot as well. So I'm very optimistic, and I'm
great.
not negative. Yeah, I'm not negative. I'm thinking it's going to happen. I can't think any other way, really. So certainly raising awareness within our commissioning services, and it started before the pilot, and it will continue. I'm not a voice that takes no easily, and I will just keep going. And if this isn't the pilot that fits the bill for Newcastle, then I'm sure I can find another one. Optimism is not a word that you hear very often in the NHS at the moment, so that's brilliant to hear, and that's why I love working with you. Yeah. Right, no, I'm definitely blue sky thinker. I can't think negatively about this. Yeah, fantastic. Chris? That'd be no good for the families, would it? So. No.
Yeah, I want to kind of highlight a proposal or idea that I've been pursuing as a child health inequality advisor with our ICB for a little while, which is actually like a first step, because what I can see here from this group, we do actually have quite a number of people who have expertise working with refugees and asylum seekers. And where it is often lacking, and I heard from people before who work in Cumbria who have small numbers, where often the experience and expertise is not there, is actually thinking of a way how this expertise can be brought to the place in a timely way where it is actually needed. Yeah? And what I have been proposing to the ICB, and there will be some high-level discussion about it, is to create something like a community of these experts and create and co-produce guidelines and educational material, which involves also like GPs, primary care services, but also involves refugee and asylum seekers themselves, and promote these around the different settings, because Northeast North Cumbria is not just Newcastle or Gateshead or urban areas. There is a lot of very remote and rural places where people are, thirsting for that kind of knowledge that could be provided at their fingertips in an easily accessible way. And that could be, in the form of guidelines or teaching sessions, or what I also propose is something like an advice and guidance service, which we as consultants, we know exists. So actually GPs or primary care professionals can ask us for advice on specific individual cases as an expert paediatrician, for example. And what I imagine is to have something like that for the entire region, for refugee and asylum seekers or migrant health in a wider sense, which includes not just doctors, may include kind of midwives, health visitors, and so forth, where actually fellow professionals can seek that advice at their fingertips with getting quick responses, which is helping patient care, reducing health inequalities, but it also has an educational element to it. And when people know, they remember that, and it helps them, even if they have little exposure, it helps them to manage the next case, which may look similar.
Chris, I think that's a really good point, and the idea of an advice service is really attractive. It would be something that I imagine would be you could set it up quite quickly. I think that the issue might be, in order to make it robust and long lasting, it would probably need to be funded. What you couldn't have is a voluntary service with 10 professionals who were keen to be involved, but actually over time drop off for one reason or another, and then the thing's not, it's not comprehensive enough, or it's unreliable. I think that's the rub, isn't it? Do you think that might be something that's, as you and I both know, trying to build these things into job plans in the NHS at the moment is extremely difficult?
Yeah, that's what I'm aiming for, because my argument is this is compared to developing fully fledged services, this is a relatively low-key, low-cost intervention that could still have quite a significant impact. So I'm hoping that they can see it from that perspective. And I fully agree. It has to be something that is funded and that is robust. This is why I'm taking it to the ICB.
Fantastic. Yeah, hopefully some of the data that we've talked about today will help make those arguments, not just the stuff from the Becky's service and your own clinical service, but the academic work that Beth has presented, the qualitative stuff that we've hopefully going to be launching shortly. All of that just hopefully strengthens the case. Has anybody else got any comments to make on that particular question, or anything else for Becky before we move on? No. In which case,
can I just
oh yeah,
sorry to interrupt. It was just I didn't answer the question around the movement of the children at very short notice. And what I would say is that we have a say in that. I very much argue the case for those families. If I'm made aware, if I've got that relationship with a family and I've been made aware that they are going to be moved and it could be detrimental to that family, I will absolutely cut out the middleman and go straight to the Home Office. There is no ifs or buts. If it's not right for that family to move away from their health provider, then I will absolutely make that argument, and I would strongly advise that other people in the room do that. It's not acceptable, and the more we do it, the more I'm hoping that it'll stop.
Yeah, absolutely. Oh, Liz, Beth, sorry, you've got your hand up.
Yeah, I mean, again, I feel that this movement and this lack of communication with health professionals is another example of structural violence in that it is so flipping dangerous. We know it's dangerous. And we all just seem to think that it's happening on an individual basis. I've been to the Home Office and refused to let them move a woman as well, who was 37 weeks pregnant and had 2 episodes of antenatal care, one in Germany, one in France, and been in the UK 48 hours when she pitched up in Newcastle and they wanted to move her again. It's like, you can't. She's 37 weeks pregnant. She has to stay. But it's not individual. It's happening again and again and again. And this is why I don't know who needs to deal with this, but it needs taking to the Home Office that it needs to stop, because it's dangerous in terms of we want to reduce. With one hand, our government is saying we want to reduce adverse outcomes. So this is one way that they could do it, of actually not moving people without telling us about it, so that we can help to keep them safe. Thank you.
Sarah, I think you've got your hand up.
Yeah,
Sarah
just
Brooks.
exactly the same. So on the neonatal unit, we've had families there that have been moving, but who coordinates all of that? Who actually is the person that liaises with those external bodies to support the family? Because we didn't have social care, safeguarding. They said it wasn't within their remit. So it was down to us as community nurses to liaise with these professional people to get a baby home safely, when they wanted to move the parents to inappropriate housing for a baby that had been born early. And it was really difficult, and it went on for a couple of months, resulting in a longer stay in hospital and lots of uncertainty, and bringing back to all of that trauma for the families. It just enhanced that negative experience and could potentially have long-term effects on the family, the whole family system, really.
Yeah.
So, which is why I've put in the chat around the early help. So as soon as you've got a family that are admitted to your unit, looking at their wider needs, whether it needs a coordinated response, and absolutely any refugee or asylum seeker will need a coordinated response for discharge. So that would be what I would be doing as a matter of standard, offer a team around the family for that family individually.
We really struggled with the actual external sources, early help, and coordinating all of it, really. Yeah, there wasn't really a lot of support there for us at the time, which is difficult.
So I think in Newcastle, our early help model is that health are very much embedded in early help. We are the key partners within that arena, and certainly commissioned to deliver early help. So that must be different in South Tyneside, is that right?
It was actually South Tees that I was working at the time.
Right.
But yeah, it was just really difficult to coordinate and to find out who was actually responsible for coordinating the whole discharge process at the time.
Okay, we're running towards our last few minutes now. Marika, have you got a quick comment to make before we move on to talk about Chris's presentation?
Yeah, we have just updated our discharge policy in NUTH to have special attention for vulnerable populations, but I will double check if this refugee population is mentioned there specifically, yes or no, because it still needs approving.
Yeah, that's a practical measure. Which leads me on nicely to my question for Chris, which is very prosaic and also equally practical, which is, when are we going to see the data that you've presented today published? Is that something which is in progress at the moment? And yeah, because again, it's getting these things into the sort of public domain is really powerful, I think.
Yes, that is in progress. What I showed there were quite preliminary analysis, so I haven't actually on purpose not shown very many numbers because that still needs a bit of work. But so far, and compared to the previous data, including from Australia, so there will be good opportunities to compare, obviously, but also we have a bit more of an in-depth analysis. And the thing I want to highlight is resilience factors and the role of resilience and how that can kind of prevent adverse outcomes. I don't think anyone has actually studied that before with this particular population, and I think it's going to be a very interesting paper, but it will still need a little bit of time to pull it all together and write it up in a coherent way. But yeah, so that will definitely come out at some point.
Yeah, it's amazing to see how much sort of academic work is being done within our region around this field. And I mean, it might be a conversation for another meeting, but how the ARC might be able to sort of help those of us who are sort of peripherally involved in academia get more involved and build this as a research theme, and how to sort of pursue funding opportunities to do that. I'm sure Beth's thought about this long and hard, and obviously we're going to be doing this qualitative project together soon, and perhaps that's a conversation that we can have ongoing in the next kind of few weeks. Okay, has anyone got anything they want to ask Chris about the stuff that he presented before we sort of start to round things up and try and finish on time? No. In which case, I'd just like to... Oh, sorry, Ailey, you got your hands up.
I was just going to say, I think you need to go and speak in Parliament about the benefits of having refugees in this country, because that was really, really powerful. And that needs to be kind of like that message needs to be really, really loud, doesn't it? Because you're absolutely right. Yeah, thank you.
Brilliant.
Yeah, I will go if they invite me, but no one came to me yet.
You should write to your MP and suggest it.
Yeah, yeah. I think the discussion is a bit more adverse, really, as Beth also laid out, and it's so polarized. That is my impression, that it's difficult to be rational and evidence-based. So even if you have good arguments, people may not want to listen necessarily because it just contradicts their own
narrative,
polarized viewpoint.
Mm-hmm.
But at least at my local level and the communications I have with people or the sessions like this one, I want to bring this point home. Yeah, because it's not just my opinion. There's actually good evidence to support that.
Yeah. Well, I think that's a nice point to end on, and clearly, based on what we're seeing in the chat and the quality of the conversation that we've had today, you are achieving that, and as has the rest of our panel. So it just remains for me to say thank you to all of the panel for their talks and their engagements, and to you, the participants who've made time this morning to listen to them and to engage in the conversation. What's really heartening as well, looking through the chat, is to see people making those connections that this huddle is here to sort of facilitate. Lots of chat going on between people in the north of the region, the south of the region, email addresses being exchanged, which is really heartening. And it seems to me that these themes are becoming more prominent and spoken about more frequently. And I don't think that's just a case of my ear being more attuned than perhaps it has been historically. I think that's a genuine phenomenon that people are talking about this stuff because it's so important. And certainly, you know, we're seeing a changing demographic as more people arrive here, and the care needs you really need to be optimised. It is kind of shocking where the gaps are. But on that note, I'll end and I think pass over to Amelia, who's going to talk about On the Horizon. Is that okay, Amelia? Are you ready? Oh, we can't hear you. Or Jen, perhaps? Are you available to talk?
Hi, Amelia was going to come on and talk, but
she's run away.
The tradition of today, she's just been kicked out of the meeting. So, yeah, this is par for the course, I think. I think this is the brilliance of the discussion session, is we didn't have to rely on the technology as much. I will just see if I can share the slides myself.
Okay.
And then I can just cover off this last bit for you. Can you see those on there?
Yes,
yeah, we
right.
Can. Yeah.
Oh, I don't really want to be right at the right at the start of the thing. Oh. Are you back on, Amelia? Oh, amazing.
Yeah, huge apologies for that. Not quite sure
what a mare. I don't think
happened.
we're going to run one of these from the office again, are we? It's not even worth it.
No, so I'm just going to share a little bit about the work that's happening from the network. So we've got our Healthier Together app and website, which there's a lot of work ongoing, and there's possibly opportunity here linked to the current themes from the call today. So yeah, lots of work going on, and our ask to you is that you're able to promote it with the families that you work into. And there's the QR codes there to access it from the App Store. We're really keen to have engagement from you, and we have a new LinkedIn page, so please do add us on LinkedIn. We've got a number of different resources. We've got our Huddle program. We have our oral health huddle coming up, so it'd be wonderful for people to attend that. And the invites and the opportunity to register is shared in our weekly Child Health Tuesday bulletin. So if you're not a member, we'll put the link in the chat, and you can join the network through the link. And it's a MS form. And as a network member, you'll receive quarterly newsletters and the weekly bulletin. You also have the opportunity to contribute to that bulletin as well. If you have resources, events coming up, information that you want to share. Number of links on the next slide, and that's to access. We also have our Youth Voice Network. So if you're working with young people across the region, and you are keen to promote their voice and join our network of youth voice groups, we welcome new members to that network. So please do fill in the form to access that area. Stay in touch with us. There's a QR code there to join the network, or you can join via the link. But final thank you from the network to our speakers. We really appreciate all the hard work that's gone into today's session, and please do keep in touch with us, and we'll look at our future schedule and our future programme. So when you receive the email with the recording, there's a feedback form for attendees to fill in. If you've got ideas for our next topic, please do share them with us, and we'll be in touch with you to follow that up. So yes, so we're going to give you 4 minutes back today. So thank you very much for your time.
Thank you. Bye.
Thank you.
Thanks. Bye.